Thank you all so much for joining us for the first session of our point of care ultrasound instruction for physicians and practitioners. I hope that you have been able to take something away from this class that will make you more confident and competent in your scanning. And I appreciate any feedback that you can provide to make this course even better. Moving forward, we're going to be offering additional sessions in the near future where we'll focus more on individual exams that you might find more useful in your clinical practice. But this original course is really intended to provide you with the information that you need to be successful in scanning those additional pieces of anatomy. So as you move forward and add to your scanning protocol, try not to forget these the practices that we've discussed here, because they can really make or break your scanning, which can also really affect how you feel about it and your comfortability using it. So today we're going to just wrap up a little bit about what we have done throughout the class and just provide a very brief review of some of the main things that you want to think of going forward in your scanning. So in review, utilization of appropriate scanning protocols and physics principles optimizes the use of ultrasound. When we don't have the skills to optimize our ultrasounds, lots of times we can produce low quality ultrasounds, which can either result in a lot of false positives or false negatives, which can affect patient care, or just simply make it so that as a practitioner, you won't find it useful, or you'll feel that it's frustrating and give up on its use altogether. So in order to prevent those outcomes, we want to make sure that we're practicing these good scanning protocols. So in briefly, some of the details we want you to remember from this course. First of all, don't be afraid to adjust your frequency for penetration. If you're under penetrating, that would mean that you're losing your beam, or you're getting a lot of darkness in the far field or at the deep part of your image. If that's the case, you're going to want to decrease your frequency to get more penetration. If you have plenty of penetration and you feel like you would like to see a little bit better detail or resolution in the area that you're imaging, that's the time that you would want to increase your frequency. So high frequency, good detail; low frequency, good penetration. The other thing is we get in the habit of using certain transducers for certain exams, but sometimes you want to make sure that you're not afraid to switch transducers. If you have a really large patient that you don't usually use, you may usually use a linear probe that has a high frequency range to assess a certain vessel, but you're struggling because the patient is large. Don't be afraid to try a curvilinear at a lower frequency, because that can really prevent a lot of frustration that you can have from the inability to penetrate the tissue. So always be willing to adjust probes, adjust frequency. You also want to use appropriate presets. Your manufacturer of whatever equipment that you have will have appropriate presets such as abdomen, vascular, GYN, things like that you would select off your computer screen. Lots of times we're so anxious to get scanning, we turn it on, we grab the transducer, we start with whatever's been last selected. And with that, a lot of the settings will be off if we don't have the appropriate protocol selected. So it can save you a lot of time and frustration just to take that moment, select the appropriate preset, and get started with your scanning from there. Another thing you want to make sure you're addressing often and efficiently is your gain. Adjusting your overall gain. If we turn the gain up, we turn our brightness up. If you turn the brightness up too high, you can actually have so much signal that it can cover things up. So you want to make sure that you have just enough brightness to see everything, but not so much brightness that you're going to be covering things up or decreasing the contrast so much that you can't differentiate anatomy that's very similar in architecture. You also want to be able to adjust that gain down, but make sure you don't go so far down that your image becomes so black that you've actually blackened out or covered up existing anatomy or pathology just because you've removed the echoes representing it. And one good example of this is thrombus. Thrombus can have a low level echogenicity, and so it's really easy to think, oh, that might be an artifact in that vessel. I'm just going to turn my gain down. that would really just be covering it up, the pathology, rather than providing the accurate information. A gallbladder is another place where you can get too low of gain, which could cover up something like sludge. You also have a TGC, which now our overall gain that we just talked about, it's going to adjust every echo on your screen to the same degree. However, your TGC, or time gain compensation, these are the little row of gain adjusters, usually to the side of your console. These gain adjusters allow you to increase or decrease your gain from top to bottom of your image to keep it bright, of equal brightness. So most of the time you're turning up your gain at the bottom and down at the top, and that compensates for your overall loss of beam intensity as it goes through the patient. Another really important tool on every console is the focus. The focus allows you to maintain optimal lateral resolution, which would be the ability to differentiate between two objects of anatomy side to side. We're going to have optimal lateral resolution to differentiate two objects side to side at the level of our focus. So if you're looking at something at a specific level, you always want your focus at or just below that level. Anything distal or beyond the focus is going to have a gradual decrease in resolution. Another useful tool in our B-mode or black and white scanning is harmonics. Harmonics really adjusts the frequency that our transducers are listening for. And so with harmonics, we are often able to provide better resolution by turning our harmonics on. However, it can also compromise our penetration, so you can turn harmonics off if you have a patient that's difficult to penetrate. But this can work really well, especially for you as practitioners if you're trying to track a needle tip or maybe look for a catheter placement or something like that. It can be really useful in seeing those types of echogenic structures and also just overall improvement of resolution. Dynamic range is really something that controls our contrast. So if I have something that I want to see a lot of shades of gray, maybe I want to compare the liver and the kidney, I would want to increase my dynamic range and make it a larger number. If I wanted something with higher levels of contrast, less grays involved, I'd want to decrease my dynamic range to make it more contrasty so I could see those big changes in anatomy. So things like your gallbladder, vasculature, things like that can be really good to image at a very low dynamic range. And finally, with B-mode imaging, you really want to concentrate on your depth. Lots of times, I know especially with our sonography students, we see they're scanning beautifully, and yet their image is only taking up maybe a third of their screen, and the rest of it is just wasted space because their depth is too deep. So make sure that you are going to set the depth just below the anatomy that you're interested in or the organ that you're viewing. Anything beyond that is just going to cause the anatomy that you're interested in to get smaller and smaller and smaller, which will of course affect your perception of the anatomy at that point. So when I'm first watching somebody scan, just we're always reminding our students, okay, adjust your depth, adjust your focus, increase or decrease your gain, and make sure that you have the appropriate frequency. And we're coaching them all the time to consistently make those changes until those things become habit. Things like your dynamic range, your harmonics, we use those slightly less frequently, but they can be very, very helpful in the right circumstances and save you a lot of grief when you're having difficulty seeing things. So with that, that's really the majority of our B-mode details that I wanted to review. I want to talk a little bit about color, and then we'll be done. So color Doppler, remember, demonstrates all motion. So it can demonstrate tissue motion, urine motion, and blood flow. Most of the time, we're not that interested in tissue motion or don't want to see it. We really don't look for urine motion very often unless we're looking for jets into the bladder. So most of the time, we're really using color to evaluate blood flow in the vessels, or even just within the parenchyma of an organ to see how much blood flow is present there. So when we're utilizing our color Doppler, we have to remember that if we are insonating or directing the sound at 90 degrees to the blood flow or the Doppler flow, we will not get feedback. So it's really important that we either are angling our sound waves so that it's not hitting the vessel at 90 degrees, or if we want to maintain that vessel in 90 degrees to get good signal back in B mode, we can layer a steered color box over the top, and that steering of the box would allow insonation of the flow at something off of 90 degrees. So don't be afraid to steer your color box. Make sure you remember to do that. If you don't have a color box steering, or you can't utilize it for some reason, know that if you just get your vessel angled across your screen, you can accomplish the same sort of improvement in visualization of color flow. Another good practice with color, if you want to have the most sensitive color possible, you turn your color gain up as high as possible, and then you tapered off on it until just all the artifact is gone and everything is real. If you just turn color on and assume it to be at maximum sensitivity, lots of times you can be missing data. That brings us to color scale. If you have your color on and the vessel or the parenchyma is not showing any color, the vessel is not showing full filling, it might be that your color scale is too high. So the first thing you would want to do is try your color gain. If that didn't solve the problem, then you actually want to bring your color scale down, so it's looking for lower flow. And once you bring that color scale down, you should start to see more filling of a vessel. You should start to see better vascularity in an ovary or a kidney or something like that. And so bringing that color scale down shows us lower levels of flow. Some systems also have a low flow button that you can do it, and it automatically adjusts the scale for you. Now, if you're imaging, say, the carotid or a vessel, and you're seeing it's mostly red, but it has these flashes of blue right in the middle of the lumen or outside of it, that would indicate that there is some aliasing, or that your color scale is set too low. So the first thing you would want to do is to start increasing your color scale, and then you should see that aliasing disappear. One other thing that we use color scale for is we can differentiate directional flow with it. So when you have your color on up in the right hand or left hand corner of your screen, you'll often see a bar, a color bar, where there will be a baseline with usually red on top and blue on the bottom. And when they're set up like that, it's going to indicate that there's red blood flow. The color red is representing blood flow to or toward the transducer, whereas blue would be representing blood flow away. If you were to do something called invert or flip that color box, then it would say that anything that had the hue that was blue would be towards the transducer, and anything red was away. And we can use those to differentiate between arteries and veins, even if we happen to see one that's flowing toward, that we want, maybe a venous, maybe a leg vein that's flowing toward the heart or toward the transducer, but we still want it to look blue. We could invert a map like that. That brings us to spectral Doppler. So spectral Doppler is often layered on top of our color Doppler. So we have our B mode, or our black and white in the background. Then we turn our color on. Our color fills those vessels or shows us where their blood flow is. And then we add in spectral, which is an actual gate, which we are going to put within the vessel or tissue that we want to Doppler. That gate is called a range gate. We usually are using these in vessels. So if you were to be using a range gate in a vessel, you would put it to the center of the vessel. You would be able to change the size of the gate, making it wider or narrower depending on the amount of flow you wanted to sample. Once you have that range gate, you need to add in a Doppler angle. So you have to have a Doppler angle because just as color flow can pick up Doppler signal at 90 degrees, spectral can't either. And so we put a Doppler angle within the vessel. We want to make sure that that Doppler angle is parallel to the vessel wall, and then you would want to update it. Now, one thing with the Doppler angle, you can only operate a Doppler angle between 0 and 60 to get accurate velocities. If you're not really looking at velocities, you're looking more at relationships of flow, like maybe you're taking a pulsatility index or a resistive index, or you're just looking at systolic over diastolic ratios. When you're looking at ratios, you don't really have to worry so much about your Doppler angle, but anytime you're looking at a velocity, you do. The equations that calculate velocity from a Doppler shift, from a Doppler angle, require the utilization of a cosine of every individual angle to get accurate velocity. So if you want an accurate velocity, use an angle, make sure the angle is parallel to the vessel wall and between 0 and 60, with 0 or 30 to 60 degrees being optimal. Now, once you have your angle set, you hit update, you start to get a spectral display on your image or on your screen. And so your spectral display is going to represent velocities of flow over time. So with these velocities, we can actually take measurements and look at maximum or systolic peak, diastolic peak. You can also look at flow patterns that would indicate levels of resistance. So sometimes we maybe can't see in the internal carotid artery. Sometimes you aren't able to see this stenosis very well, but just by watching the velocities change and the flow patterns change, demonstrating more or less resistance, you can get a pretty good insight into what may be going on in that vessel without actually visualizing the vessel wall itself. That brings us to scale. So as you have your spectral Doppler running, you might see that the waveform is only taking up half of the graph. In that case, you'd want to decrease the scale to spread that waveform out, making it easier to assess. Now, if you happen to have a waveform that's wrapping around, or it's going off the top of the scale and peaking at the bottom of the scale, that would indicate there's an aliasing, and you would want to increase your scale in that case. You can also use gain to provide more or less signal of the Doppler, of the spectral signal as well. So increasing your overall gain would increase the brightness of the signal on your spectral analysis, whereas decreasing it would take some of that data away. All right, well, in summary, utilization of optimal beam mode, color mode, and spectral Doppler benefit the quality of examinations. Ultrasound is notorious for not just being able to demonstrate anatomy and pathology, but if used improperly, it can also demonstrate things that aren't there. So you always want to be looking and making sure not only are your images representing what is there, you want to make sure that there's nothing that is artifactual showing up on your images, making it look like there's something abnormal when there's not. Without the use of good scanning procedures, ultrasound can be of very limited usefulness. It can even result in false positives and false negatives that could dramatically affect your patient care, as well as your confidence with the utilization of these devices. However, used with optimal techniques, ultrasound can be very effective, efficient, and cost-efficient in your medical practice. So we really do appreciate you joining us for these courses. If there's anything we can do, if you ever need additional help or clarification on anything, or just want to follow up with us for maybe a scanning tune-up, please let us know. And we would happily be there to help you as soon as possible. Thank you so much again for joining this very first class that we're offering and going through some of the growing pains with us. And we look forward to working with you in the future. Thanks.